Hotbed Talk.
Hello, my name is Daniel Engelman from Baystate Medical Center in Springfield, Massachusetts, USA. And today I'm going to talk about some of the updates in the ERAS Cardiac Nonprofit Society. I have no relevant financial disclosures related to this talk. As I like to start most of my talks, I will point out that 80% of the preventable morbidity and mortality following cardiac surgery occurs outside of the operating room. It comes from a patient that has either not been adequately worked up or optimized preoperatively, or some postoperative lack of standardization, which results in a preventable morbidity and mortality. The ERAS Cardiac Society has as its primary goal to standardize evidence-based best practice to decrease preventable morbidity and mortality to the lowest possible rate. This is not fast-track surgery. This is an advertisement that went around in the United States decades ago, talking about how their newest Oldsmobiles were not like your father's Oldsmobile. And the reason I like to show this slide is that my father is actually the, quote, father of fast-track recovery. And in this manuscript in the Annals of Thoracic Surgery in 1994, he published his fast-track recovery results, which basically used a set of interventions to try to get patients home quicker and to prevent readmissions. ERAS protocols are sort of an extension of that. They've been successfully applied to multiple other surgical specialties, and our European colleagues will tell you that they're ubiquitous throughout Europe after every type of surgery. Colorectal really is what started this in the perioperative framework, and then it expanded to every other surgical subspecialty. Upper GI, GYN, orthopedics, general thoracic. But what about cardiac? Well, they said, well, cardiac's too complicated. We can't do a successful ERAS in cardiac surgery because of this, the cardiopulmonary bypass pump, with all of its flow problems, dynamic changes in volume, blood on the floor. We can't keep track of how much blood we've given in real time, temperature management problems. It seemed too complicated at the time. But in 2017, a group of like-minded cardiac surgeons and critical care anesthesiologists got together, and we said, well, maybe we could try to see if there's interest in doing this around cardiac surgery and standardizing best practice. So we met and we formed a small group, which then got a lot bigger the following year. And when we formalized our agreement with the International ERAS Society in Sweden, and the group became a lot bigger. And we developed a mission, which was to optimize the perioperative care of cardiac surgical patients through collaborative discovery, analysis, expert consensus, and dissemination of best practice. And we've stuck by that mission. And that culminated in 2019 when we published in JAMA Surgery the guidelines for perioperative care in cardiac surgery. And these guidelines were successfully implemented in multiple other studies, one of which came out from Dr. Williams. And he, as well as multiple other hospitals, have all shown the same thing following cardiac surgery. And that's with a rigorous attention to standardizing best practice. They were able to reduce opioid use, reduce GI complications, reduce length of stay, as well as reducing readmissions, all of which have direct consequences on outcomes, payment models, and actually just better care for our patients. This is a summary of Dr. Williams' protocol, and this is pretty typical of most of the ERAS cardiac protocols. They're divided up into preoperative, intraoperative, and postoperative components, and I think that this slide really does a great job outlining some of the interventions, which really start preoperatively. There's a lot of attention on preoperative education. We use nurse coordinators. We do prehabilitation. That's to take patients who are frail, who are immobile, who need a little bit more activity before their elective surgery to get a better outcome after their surgery. It's smoking cessation, alcohol cessation, and nutritional optimization. And then the day of surgery, we no longer make our patients MPO at midnight when they're going to have an operation the following afternoon. We give them a carbohydrate clear drink 2 to 4 hours preoperatively, and we use multimodal analgesia up front. And then throughout the operation, we continue with less opioids, and we pay very close attention to temperature management, to decreasing the chance of having a postoperative infection through stewardship of our antibiotics, and then careful goal-directed fluid management, which starts in the operating room and continues postoperatively. And postoperatively, a lot of attention on early extubation, ambulation, decreasing opioids using multimodal analgesics, getting the tubes, wires, and lines out at the soonest possible time. And this publication from Dr. Grant out of Hopkins showed that as they increased the number of process measurements, seen here with acetaminophen, gabapentin, using a protective lung ventilation strategy in the operating room, ketamine, dexmedetomidine, a paralytic reversal, and a regional nerve block at the time of surgery, the more of these process measures they used, the quicker they had to extubation, as well as the decreased time on the floor, decreased length of stay, and they had great compliance, very few readmissions, and outstanding results. So some of the potentially disruptive evidence-based recommendations from the ERAS Cardiac Society include the following. We suggest that our accepted perioperative practices up to now may actually be wrong, that elective patients probably should be optimized with up to 4 weeks of prehabilitation prior to surgery. And in the United States, that really goes against how we've been treating most of our elective cardiac surgical patients. We usually operate on them at the soonest possible slot. But it turns out that patients who are malnourished, who have uncontrolled hyperglycemia, who may be anemic, who may be frail, who may be using hazardous alcohol use or smoking, all probably should be intervened upon preoperatively, and all of these things reversed in order to optimize the patient prior to elective cardiac surgery. We also think that we need to end the preoperative dietary restrictions. We need to consider rigid sternal fixation over the standard wire cerclage, because multiple randomized controlled studies have shown that these patients have better healing, earlier ambulation, less requirements for pain management, less sternal non-union, and less sternal wound infections. The ambulation restrictions probably could be liberalized. They're outdated, and especially with a good rigid sternal fixation, we probably could get people up doing their activities of daily living earlier and quicker. Chest tube management strategies need to be looked at. We need to keep our chest tubes patent early on and then removed at the earliest possible time frame. And AKI could probably be reduced. There are multiple ways of doing that. I've been personally focusing on using biomarkers in order to identify stressed kidneys and patients that probably require very aggressive goal-directed fluid therapy to reverse the kidney stress and prevent the subsequent development of acute kidney injury. And probably stage 3 acute kidney injury probably should be put more into the realm of a never event. We probably should not be accepting stage 3 acute kidney injury as the fact of doing high-risk cardiac surgery, and each of those cases needs to be looked into and to see whether or not maybe that could have been prevented. Perioperative medicine probably should be its own subspecialty. It includes the preoperative time frame as well as the postoperative time frame, and specialists need to be focused on this particular area in order to improve outcomes. And it's true, it probably may be more important to outcomes in this day and age than the intraoperative component of cardiothoracic surgery, because we've become outstanding at performing excellent cardiac surgery. We've standardized best practice in the operating room to the point where the marginal gains we can get in the operating room are relatively small compared to what we can get through better preoperative optimization of our patients and postoperative care with standardized evidence-based best practice. And then we start thinking about what is patient-centered value. ERAS is all about patient-centered value. Value is defined as the patient's reported outcome divided by the cost. And the core principles are we need to standardize evidence-based best practice to reduce complications, pain as reported by the patient, the length of stay, the cost, and readmissions. Prehabilitation, preoperative carb and clear liquids, multimodal analgesia, and attention to temperature and glucose control, both in the preoperative, intraoperative, and including the postoperative time frame, a absolute attention to a infection prevention bundle, perfect sternal closure, early extubation and ambulation, and we need to prevent pericardial and pleural effusions, and we need to do whatever we can to discharge patients to home and not to a skilled nursing facility or rehab facility, because that's really where they're going to do their best. We need to involve our nursing colleagues, because they really are the front line of this. In this nursing journal in 2018, Dr. Williams and his team were the cover in discussing all of the nursing interventions, which can actually be patient-centered, and it really requires a core team with nursing leadership, advanced practitioner leadership, and physician champions to really make this work. It's not easy, but it really has huge benefits for our patients. These are some of the key data elements for collection in an ERAS cardiac surgery program. So you're going to start a program and you don't even know where to start. You're saying, well, what should we be collecting? How do we get metrics? How do we get benchmarks? How do we know we're even improving? And these are some of the things that we've come up with as a society, which we have in press, and these will soon be published. And they include preoperatively, we should probably be measuring albumins, hemoglobin A1Cs, what percent of patients were actually NPO for longer than 4 hours prior to surgery? Did they get their carb loading shake? We should get some baseline 5-meter walk tests. Did they have prehabilitation? Did they actually go there? Did they get their glucoses optimized? Are they going into the operating room with an A1C that's through the roof? They're going to be at huge risk of postoperative complications. All of this needs to be fixed before surgery. Intraoperatively, we have to look at sternal closures. We have to look at how much opioids a patient receives in the operating room, because opioid-induced hyperanalgesia is a real thing. The more opioids that are given to a patient during the operating room, during the operation, the more opioids will be required to take care of their pain in the postoperative time frame. And the key here is to decrease opioid utilization throughout the patient's hospitalization. We need to have strict, tight glucose control, but we do not want hypoglycemia. So that requires a real attention to glucose. And finally, we also need to really think about multimodal analgesia. We need to give some drugs up front. We need to give some drugs during the operation. We need to start thinking about regional blocks, which more and more data is showing actually works in cardiac surgery. And then post-operatively, we need to de-escalate the amount of opioids we're using rapidly and have situational awareness surrounding our opioid utilization. Early extubation is important. Ambulation needs to start on post-operative day number 1. We need to absolutely be screening for delirium and doing whatever we can to prevent it by not giving patients benzodiazepines, by not altering their sleep-wake cycles. We need to pay attention to getting our patients oriented to time and space. Goal-directed fluid therapy will reduce acute kidney injury following cardiac surgery. All patients need chemical thromboprophylaxis. Patients who have cardiac surgery are hypercoagulable despite the blood transfusions they get and the coagulopathy we think we see with all that heparin and all that bleeding and the pump run. They are hypercoagulable. They get DVTs, they get pulmonary emboli, and they need chemical thromboprophylaxis. And finally, we need to think about how many opioids we're actually giving to patients upon discharge. The just-in-case prescription needs to stop, because those opioids end up in patients' and family members' medicine cabinets and end up in dangerous places. And we want to stop giving these opioids if at all possible. So now I'm going to talk about just a few highlights in this whole big package of where we're going with ERAS cardiac and some things to think about. The first is patient engagement. We need to engage our patients. It's patient-centered care. We need our patients to actually take part in their own care and find out what they're thinking in real time. And how do we do that? At my hospital, we use a patient engagement technology, which gives us patient-reported outcomes, PROs, in real time through their phone or their iPad or computer. They can use it. Their spouse or significant other can use it. And what it allows us to do is monitor patients in real time when the nurse or the advanced practitioner or the physician is not in the room. And we've been able to show that by utilizing this technology, we've been able to decrease length of stay, readmissions, as well as discharges to skilled nursing facilities. And we can benchmark these patient-reported outcome measures and compare them between other hospitals that are giving the exact same questions to the patients on the exact same days. and we can compare best practices. We can utilize these patient-reported outcomes to improve early mobilization, and that was one of our enhanced recovery after cardiac surgery multi-center collaborative projects where we're comparing different sites. And we can also benchmark and look very closely at readmissions, which really is the goal here. You can send a patient home early, but if they're coming back, if you're getting increased readmissions, then you were not successful. And then finally, this leads into my next topic, which is opioid tracking. So one way we can track opioids is actually asking the patients every day, how many of the pills that you were prescribed did you actually take on any given day? So they can report how much pain they have and how much pain medication it took to relieve that pain. And we can compare that in real time, over time, and hopefully see that de-escalating. But that then brings me to my second point, which is how do we reduce opioid consumption? And really the answer is we need better situational awareness. We don't really know on any given day how many opioids a patient's taken in the prior 24 hours. So the objective of this project was to taper down opioid utilization to minimal levels between the time of surgery and discharge. And what we did was we programmed an app that was built into our electronic medical record. It works on all of our Epic and Cerner systems, which are ubiquitous around North America, which then shows a daily patient MME consumption beginning in the operating room and extending all the way to discharge. And it pulls all of the opioid administrated data out of the medication administration record, all the opioids that were given, and immediately calculates and converts them to a value. So we actually have some sense of total MME use. And that's one of the key questions I ask when I round on every patient postoperatively. How many MMEs did they take in the prior 24 hours? And show me that graphical display. I want to see it de-escalating. And here's a typical screenshot from a patient. You can see over here that the patient had a cabbage here over on this day. And here's the MME. And then on the next day, we can see it decreasing until we get into the preferred level right around here. It shows us the opioids that the patient's receiving, as well as the non-opioid pain medications, the multimodal drugs, which in this case were acetaminophen as well as gabapentin, which we use a lot in our patients to try to decrease the opioids that are administered. And you can click on any given day and see the breakdown of which particular opioids the patient's gotten on that day. And really, we think this is absolutely contributing to our ability to decrease opioid utilization. But time will tell whether this really lowers the bar for us and improves outcomes, decreases pain to our patients, and allows for less opioids and more mobilization. I'd like to thank everybody for their attention and for this invitation to speak. Good day.
Dan, thank you so much for that fantastic presentation.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.